Good afternoon, everyone. My name's Sarah Young. I'm the Deputy Dean of the Medical School, and unfortunately Barry couldn't be here today to introduce our speakers, so you've got me instead. So thank you very much for coming along. We're going to have a fantastic presentation today, I'm sure, by Professor Mike Williams and Dr. Sean Coffey, and you can see the title. They're both going to speak today, and then there'll be time for questions at the end. Now we do have people online watching this presentation, so if we do have questions from you at the end, we will have to ask you to speak into the microphone so we can make sure all of the people online can actually hear what's being asked and the response. So thank you very much, Mike.
Sarah. So today we're going to talk about myocardial infarction, and traditionally our understanding of a presentation is that usually there will be an underlying atherosclerotic plaque rupture, evidence of thrombus, and so as clinical cardiologists, when we go to the cath lab and do an angiogram, we would expect to see some sort of residual stenosis. About 10% of the time, in a person who's apparently having a myocardial infarction with clinical symptoms, ECG changes, we see nothing. And often it's been underappreciated that this could be the real thing, and clinicians have tended to think maybe it isn't a myocardial infarction. We'll discuss some of the other diagnoses that it could be. And there's a danger by not understanding that it is a myocardial infarction that we might undertreat these patients with evidence-based treatments. And so the aim of our presentation today is to underline the importance of this presentation, to give a series of case histories where persons present with mimics of myocardial infarction. Then we're going to focus in on the entity itself and use some of our research findings to look at presentation and outcome of persons presenting with myocardial infarction without obstructive coronaries. So we're going to start with this woman, a 68-year-old, who was visiting her son and family in a rural area of Otago. And a traumatic event occurred in that she had a cardiac arrest in front of the family, and they immediately started resuscitation and called for an ambulance, which was going to be some time away. Up until this stage, there was no hint of any problems with ischemic heart disease. As you can see, she'd had a past history a couple of years ago of treatment for a B-cell lymphoma. It had chemotherapy and radiotherapy with a good result. There were some pulmonary nodules of uncertain significance, which had been investigated in biopsy, found to be necrotizing granulometer. There was no evidence of residual lymphoma, so she was essentially cured. She'd gone forward and had a successful right ankle replacement in 2017, and she had a peripheral neuropathy as a sequelae of her chemotherapy. So this is the presentation rhythm when the St John ambulance arrived, and I think there was at least a 15 or 20 minute delay, so there was a sustained period of resuscitation by family members, and you can see that she was in ventricular fibrillation, and after the first shock returned back to sinus rhythm. And about 3 minutes later, she had recurrent ventricular fibrillation and was successfully shocked again and then maintained sinus rhythm. So the time there was at about 19:53, and she was transported to Dunedin Hospital, where the first ECG was performed about 10:36. And it's pretty unremarkable. There are no marked ST segment changes. And it's relatively straightforward. We know what to do. If someone's got ST elevation, that's an indication to go to the cath lab. Here it's a little bit more uncertain. She'd had a return of spontaneous circulation post-cardiac arrest, and thinking it through, with a presentation with ventricular fibrillation, there was a pretty significant probability of a cardiac cause. So if we look at the guidelines of what to do in this situation with a presumed acute coronary syndrome. As I intimated before, ST elevation is straightforward. There's a recommendation. It's relatively limited evidence that you should take these people to the cath lab, because in a significant majority with ST elevation, you'll find a lesion. However, if you've got no ST elevation and no prior clinical features, and coronary ischemia is considered the likely cause on clinical grounds, which was the case here, with no evidence at all and a weak recommendation, you could consider coronary angiography, which was what was done in this situation. So the first cine shows the right coronary artery in an LAO projection, and it's completely free of significant disease. And on the your right panel, an RAO of the right coronary artery, which is also free of disease. Then we took views of the left coronary system, and I've just put two representative views up, but basically there's no significant obstructive coronary disease. So her progress thereafter was that she went through the intensive care unit. She was still intubated and ventilated at that time, and maintained sinus rhythm. There was no further arrhythmia, reasonable blood pressures. And the following morning, didn't require any vasopressor support, woken up extubated, neurologically intact, and apparently a very good initial recovery. So she was able to be transferred up to the coronary care unit. And here are the serial troponin levels, and you can see that by 0030 hours, some 3 to 4 hours after a cardiac arrest, there was a fairly significant increase in the high sensitivity troponin T, and then it fell. So an enzyme pattern of a probable myocardial infarction, not much in the way ECG changes, and no obstructive coronary disease. What's going on? And I'll turn over to Sean Coffey to answer that question.
All right. Thank you, Michael. So we're now in the situation where we've had someone who's had a very significant cardiac event without any obvious cause. And so it makes us ask a few questions. First of all, has she had a heart attack? Because that's the most obvious thing. That's what we were looking for when she was sent to the cath lab. But the arteries were clear on the angiogram. So if it's not a heart attack, then what is it? And of course, at this point, we don't have any further information to point us one direction or another. But actually, we start to get a little bit philosophical at this stage, and we say, well, what even is a heart attack? You know? And once you start going down that road, you start getting a bit more existential. You say, do I care? Should I even care? Right? But those are important things, because maybe this is just something that we end up seeing that is no implication longer term if the coronaries are clean. And those last two questions, the caring part, I'm going to leave to Dr. Williams to answer later on. And I will focus on the other bits. And we'll go at it in reverse order. So what is a heart attack? Luckily, there are people out there, people who do a lot of research and need a lot of citations, who define these things for us. And they define them at based really around, and this has really come into play since cardiac biomarkers started to come on the scene. The more sensitive these have become, the more we're starting to diagnose things where the troponin or marker of cardiac injury goes up without them possibly having what we would have previously called a heart attack. So this, if you think of that blue square as everybody who presents with a possible acute coronary syndrome, of these, there'll be people whose troponin remains totally normal, and you know they definitely haven't had a heart attack. But in here, in that middle, in this circular section around here, these are people where the troponin has gone up. And so the troponin has gone up, and you know because of that that they've had a myocardial injury of some description. You can't say any more than that at that point. But a myocardial infarction is a subset of that group. There are people where you have evidence of an injury, where you have a dynamic troponin, so there's been a rise and fall, but you've also got something to point to myocardial ischemia or lack of sufficient oxygen to the myocardium. And so that could be in the form of, for instance, ST elevation on the ECG. It could be in the form of new wall motion abnormalities on cardiac imaging. Or it could be just in the form that they're getting classical ischemic chest pain. And if you look at these little things here, the potential causes, so if we take anemia for an example, if you have someone who's anemic, they may suffer no adverse consequences of that. But the more anemic they become and the more compromised they become, even if their arteries are perfectly clear, they will move into that area where you have first myocardial injury and then a form of myocardial infarction without there being any problem with the arteries at all, just purely due to lack of myocardial oxygen delivery. So if we take that subset, that group where you have got a confirmed myocardial infarction, what we now divide it into is two major types. There are other subtypes, but they tend to be kind of procedural related. But the two major types we think about now are type 1 myocardial infarction and type 2. And so type 1 myocardial infarction is what everyone used to call a heart attack. It's what the general public thinks of a heart attack, where you have an atherosclerotic plaque that has had some kind of rupture or erosion, and you get a sudden acute blockage with the standard platelet aggregation. And this is what antiplatelet therapies in the form of aspirin treat, in the form of clopidogrel, ticagrelor, and all those other things like the heparins that we use to try and break down that clot and restore perfusion to the arteries. But what we've increasingly recognized with high sensitivity troponin is that it's perfectly not common, but it's something that we see not infrequently, that you would have a myocardial infarction without there being any type of what used to be called an acute MI, or now we call it type 1 MI. And these are things where you've got a fixed stenosis, so a fixed atherosclerotic stenosis that at rest may not be causing any trouble, but for some other reason, for instance, they become hypotensive in the setting of sepsis, they're just not getting enough myocardial oxygen. And so you can see these on the right-hand side here. So we've got things like the vasospasm, like coronary artery dissection, or you can have a completely clear set of coronary arteries, and it's purely down to that mismatch between what's been provided and what is being asked for from the oxygen point of view. Now, so if we go on to the next, the first question we had there is, has she had a heart attack? Now, we have this kind of flow chart where we can work our way through. And so we think about, so has she had an elevated cardiac troponin? Yes, she has. Has she had a rise or fall over here? And yes, she has had that. And so at this point, we're saying, has she had acute ischemia or hasn't she? And that will send you down different pathways. However, the reality is that this is not how patients present. And this is something that you can work through in retrospect, but actually doesn't really help you a lot at the time. And so the real world, what we see is someone presents, usually to the emergency department, with some kind of a presentation that's consistent with ischemia. And that's usually something like chest pain. But in the case of our patient, it was with ventricular fibrillation without an other obvious source. But for whatever reason, they have a presentation that's consistent with myocardial ischemia. And then they go on to have an ECG, and this is usually done to look for ST elevation. And if they've got something acute on there, they'll be sent to the cath lab. Or it may be there's nothing particular on the ECG, but you do a troponin, and a few hours later that comes up as showing a myocardial injury of some description, and at that point, then you go do an angiogram. And so then you do an angiogram, and then that can be broken down very roughly into either obstructive coronary artery disease or non-obstructive. And the definition of obstructive disease varies a little bit, but in general, it's what we're looking for is any kind of lesion that would obstruct the flow in the arteries, and that's usually taken as 50 to 70% stenosis on an angiogram, although there are other ways to assess that. But and those are the ones that are easy. You do the angiogram, there's a stenosis, and you treat that, and then everyone is happy, okay? But if we think about the patient we have, who actually have got nothing to point to on the angiogram, we've got this non-obstructive picture on the angiogram, and that has been given the label troponin positive chest pain with non-obstructive coronary arteries, or MINOCA, which really is never going to catch on because there's not enough vowels. There's just not enough. And so, but that's what this lady had at this point in time. And when we look at these sort of patients, so we're in this situation, we're not calling it an MI yet. We just don't have enough information to call it that. But they've got a presentation with troponin positive. They've got some kind of, and everything in cardiology is called chest pain, no matter what it is. But they've had some kind of presentation consistent with ischemia, non-obstructive coronaries. And then you get into what are the causes of that. And things like the extracardiac causes tend to be a little bit more obvious. So if someone's septic, they'll usually have something to point to there. And so we're left with what are dividing into the major cardiac causes, and that's usually things like non-ischemic and ischemic causes. And so the ischemic ones are the myocardial infarcts with non-obstructive coronaries, and those, it may be that you have had a plaque rupture event, but for instance, they've had thrombolysis in infarctal, and by the time they get here, the arteries are completely clear. It's worked perfectly well. It could be something like coronary vasospasm, so that you have had a stenosis or flow-limiting lesion due to the artery just clamping down, but by the time you get to the cathode, that is relaxed and it looks clear. But the other major group here are the non-ischemic causes, and those might be things like myocarditis, might be like our other cardiomyopathies. And to work these out, we've looked at the arteries, and now it's time to look at the myocardium, all right? And so if we go back to the patient that Michael described, this is her left ventriculogram here, all right? And so this is an injection of contrast into the left ventricle. And what you should see here is the entire ventricle contracting in. What you actually see, however, is that the basal segments here are contracting really well. In fact, if anything, they're probably contracting more than you would normally see. But the mid and apical segments are not moving at all. All right, and so this is a very, very characteristic presentation here. And this is called Takasugi syndrome, or stress cardiomyopathy. And what a Takasugi is just the translation of an octopus pot. And this is what an octopus pot looks like. You've got this narrow waist here for the octopus goes in, this is the mouth here, goes in here and gets trapped here because it's got that narrow waist. And that's exactly what the ventricle looks like in the vast majority of cases of Takasugi syndrome. So if we, and so that's what our patient had. Right? And in this is a condition that if the patient survived the initial period of time, they usually have an excellent prognosis. Around about maybe 5, possibly up to 10% of people die in that initial phase. But if they can survive that, they will usually recover the vast majority of their cardiac function within around 6 to 8 weeks. So if we look at, if we take it in general, if we look at people who've troponin positive, non-obstructive coronaries, and we look at the different potentials here, then acute myocardial infarction counts for around about a quarter of these patients. Myocarditis counts for around a third. And then the other cardiomyopathies, like Takasugi or hypertrophic cardiomyopathy, counts for a small number. And right at the bottom there, you find the ones we just don't get an answer for. And that's probably just because our imaging techniques are just not good enough for it at this point in time. So if we just go through a few of those other presentations. So myocarditis is just inflammation of the myocardium. This is a relatively young man who presented with a viral prodrome, but he had ST elevation on his ECG. And it's I'm not sure if that's, I'll just take down the lights here a little bit. You can see here, there's this little white patch here. This is a cardiac MRI. This is a T2 weighted signal, so it's looking for myocardial edema. And there's a little bit of increased signal in this area. And this is the late gadolinium picture here. And you can see these little white plaques just on the outside of the myocardium. And that is absolutely characteristic for myocarditis. And in most cases, this will be down to having had a viral infection. Here's another lady that presented earlier this year. So a 64-year-old woman. She had a little bit of mild hypertension, but really no significant risk factors, and had been getting increasingly out of breath for 3 months and had 2 weeks of chest pain, which was relatively exertional. And this is a very common way for myocardial ischemia to present. She had an ECG that looked like this, and I think I'm fairly safe to say here, but for ED people in Otago and Southland, this is your ticket to cardiology, because you've got a biphasic T wave here, which really is viewed as a possible proximal LAD lesion or Wellens sign on the ECG. Which it does turn out to be on occasion. But anyway, this is what gets you into cardiology. They added troponin, which was just at the upper limit of normal. And this is often, so to work out if there's a rise and fall, of course, you need additional numbers, but this is how people present at a single point in time. She had an echocardiogram that looked a little bit like this. And so if we look on here, this is the left ventricle in here, and the right ventricle just above it. And what you can see there is that the ventricle itself is a little bit brighter than you would normally expect. It's a little bit thicker, but it's not overly easy to see, all right? And it could be down to that hypertension possibly being a little bit worse than we were previously told. So she went on to have an MRI, and let's see if that, here we go. And so here's our MRI, and you can see here, there's the septum there, really much thicker here compared to further down here, much thicker than the corresponding part of the heart on the other side. And that's absolutely typical for hypertrophic cardiomyopathy, an inherited cardiac condition. This is late gadolinium imaging on the MRI, and this looks at myocardial scar or fibrosis, and you can see this bright patch right at that thickest area of the myocardium. And here it is in cross-section in here and further down here. And this, again, is fairly typical for myocardial infarction. You get the muscle will increase in size, the myocytes become disorganized, and you get a collagen laying down into the muscle itself, giving a myocardial injury, giving that appearance on the ECG. And in this lady, what I didn't show was that she had non-obstructive coronaries at the time of her inpatient stay. And one last case presentation here. So this is a 69-year-old woman, SMRT 0, and what that is standard modifiable risk factors, and so that's things like smoking, hypertension, hypercholesterolemia, basically no significant cardiac risk factors, possibly other than her age, which isn't particularly modifiable. And so she had atypical chest pain, and as is common in parts of Otago and Southland, completely ignored that for many weeks before someone sent her into her GP, and she ended up in cardiology clinic. But you're outside that window where a troponin will pick up any acute injury. Her ECG, her echo was normal. ECG showed a few kind of non-specific changes on the anterior leads, So you know maybe something is going on, but you don't know what. The echo looked fine. And so when she went on to have a cardiac MRI, actually there's a very localized area here. This is the heart in cross-section, where the pump function overall is good, which is what you'll see on echo. But this part here probably isn't contracting as well as it should be. And then on the late gadolinium images, so looking for that myocardial scar, you see a nice rim of scar tissue in the subendocardium, and that is absolutely classic for a heart attack. So this person has had a myocardial infarction, almost certainly at the time of her chest pain presentation. And so what I've just covered there is what it is, if how you define a heart attack, how you say it is a heart attack, and if it's not a heart attack, how you say what it isn't, and that involves looking at the myocardium. And I'm just going to hand back to Michael now to go on to that bit about why should we care about these myocardial infarctions with non-obstructive coronaries.
Should we care? Well, of course we care as expert clinicians, physicians. We care for and about our patients and their outcome. But as I alluded to in the introduction to this presentation, if you're uncertain about what's going on, then it's difficult to know, should we apply the normal paradigm that we normally would use after someone's unequivocally had a myocardial infarction. We're going to use double antiplatelet agents. We're going to use an ACE inhibitor. We're going to use a statin. And in a group of persons, we may consider a beta blocker. And generally that's restricted now to those who have heart failure or asymptomatic impairment of left ventricular function. And I won't be able to answer the question on what is the appropriate treatment for myocardial infarction with non-obstructive coronary artery disease, because it remains unknown. But we've conducted some research to try and get an idea of the presentation and the outcome for these persons, because if a person comes in, is presumed with a chest pain syndrome, ST elevation, maybe there or not, but troponin rise, has a coronary angiogram, and the clinician's in doubt, will that influence the way they're going to treat that patient? We don't have the resources to do cardiac MR in all patients, okay? So we've presented some lovely cases to give you an idea of how in a perfect world you might investigate such persons. But generally, it's just left to judgment. And we hoped that this research, which was recently published in Heart online, would give clinicians some useful background on outcomes for people presenting. So there may be a perception, not really based on evidence, that these people might be of lower risk than someone with obstructive coronary disease and myocardial infarction. And that's because there's a deeply held conviction, certainly amongst cardiologists, that your risk, and it's proven certainly in chronic coronary artery disease, for future events and mortality is related to the severity of obstruction of the coronary arteries. So if you have multi-vessel disease, you'll have a worse outcome over time than a person with single vessel disease. And so there's a tendency amongst clinicians to think, well, you know, if you haven't got coronary obstruction, maybe things are not going to be too bad in the future. So previous studies, and they're largely observational, as is the research I'll present today, has suggested a fairly large range of subsequent myocardial infarction or death rates, anywhere from as low as 2% up to 9.1% at 2 years. And to give you an idea, those with obstructive coronary disease will have a mortality of about 10% at 1 year. Now, the background to this study is that because we don't know whether obstructive coronary artery disease has higher rates of adverse events compared to those without non-obstructive disease, we wanted to answer that question. And we were going to determine the rates of adverse cardiac events in a national consecutive series of subjects post-myocardial infarction. And we wanted to compare events in patients post-myocardial infarction stratified by obstructive disease, and for the purposes of this study, that was persons who had a coronary angiogram, if they have any vessel with a 50% stenosis or greater, they're considered as having obstructive coronary disease. And if you have any irregularity of the coronary arteries up to a narrowing of less than 50% diameter, that's called mild coronary disease. And then those who have apparently no irregularities, they're classified as having normal coronary artery disease. And in addition, we wanted to compare the subsequent events after presentation with myocardial infarction to a large group of persons in the community, age and sex matched, who had no coronary artery disease. So the way we conducted the study is we looked at a national analysis. We had 8,305 patients, and they all had undergone coronary angiography over a period of 2 years, as outlined. And the way we collect this data is from our All New Zealand Acute Coronary Syndrome Registry, and it's called ANZAC's QI. So this is a registry that's been running now for, in its early phases, 7 years, but rolled out to every hospital in New Zealand over the last at least 3 years. And it's got two arms. The cath lab arm, so anyone who has a coronary angiogram in New Zealand, in both public and private hospitals, will be captured in this database, and therefore we can be confident that we've got all the people who had coronary angiography, and a subsection, a significant subsection of them would have had an acute coronary syndrome. And then there is another arm called the acute coronary syndrome, and that will capture people who are admitted to a cardiology unit, and a small proportion of those, usually due to other comorbidities or excessive risk, will not have a coronary angiogram. At the moment, the capture isn't 100% because it doesn't include persons admitted to general medical services with acute coronary syndrome. So we defined myocardial infarction according to the 2012 third universal definition. It's just been superseded by the fourth definition published this year in the European Heart Journal. And the aim is to try and exclude non-acute coronary syndrome conditions such as stress cardiomyopathy. It's similar to the woman who we presented as our first case. She would not fit into the group of acute myocardial infarction with non-obstructive coronary disease because she has another pathology. As best we're able to, we'll exclude persons with myocarditis, but it's almost certain that some persons do creep into this registry because we don't have the facility to do MR in everyone. And we classified them, as I described earlier, into those who had obstructive coronary disease and without obstructive coronary disease, and then subclassification into those with completely normal coronary arteries and those who had mild coronary artery disease. Now, our next cohort is a group of persons who were recruited from the community, and they're in a study called the PREDICT study, and currently that's enrolled for about 480,000 New Zealanders based at the University of Auckland. And there's fairly comprehensive descriptors of the cardiovascular risk factors available. And so we were able to age and sex match 8,305 collected who were enrolled in the PREDICT study over that time. And in addition to the cardiovascular disease risk factors, which are collected in primary care, we also have access to national databases to get any missing values of blood parameters such as lipids, glucoses, etc. So briefly, we looked at survival analysis using Kaplan-Meier study, and I'll present that, and made comparisons between the outcomes for those with obstructive coronary disease and those with mild none, and then the group who'd had no prior cardiovascular disease. Okay, so these tables are busy and large, so I'll guide you through them. And basically what we've got is in this column here, which will remain the same through subsequent slides, we've got persons who presented with myocardial infarction with obstructive coronary artery disease, defined as a greater than 50% stenosis. And then there are the cohort without obstructive coronary disease. So immediately you can see that there's about 7,408 versus 897. And then we break down this group of 897 into those who are normal and those who are mild. And I'm just going to highlight with this red box outlining some of the differences. So you can see that those who present without obstructive coronary artery disease are younger than those with obstructive disease, and that those who have normal coronary arteries are younger again than those who have mild disease. If we look at the proportion who are women, you can see that there's a higher proportion of women presenting with no obstructive coronary artery disease, and similarly a higher proportion of the group without obstructive coronary artery disease are women. If we look at ethnicity, there is a difference outlined there, and there's a significant difference in the proportion who present with ST elevation myocardial infarction. So if you have obstructive coronary disease, 35% of people will present with a STEMI, but if you don't have obstructive coronary disease, it's relatively uncommon at 10%. Smoking is more common. Non-smoking is more common in persons without obstructive disease. So if we go on to the next page of patient characteristics, same columns as before, and we'll just highlight the difference in diabetes. So diabetes more common in those with obstructive coronary disease, which is pretty much as expected, and it's much less common in those who have normal coronary arteries. ST segment deviation is much more common, as you might expect, in those with obstructive coronary artery disease. Now, what about patient management and outcome? Because that was one of the reasons for doing this study. And I'm just going to highlight some of the points. Again, the layout of the columns is the same. So aspirin, a fairly basic treatment, you'll see that 97% of persons with obstructive coronary disease are treated with aspirin, which is what you would expect. But if they don't have obstructive coronary artery disease, there's a relatively major drop-off, right down to 90%. So that means someone's thinking about this and making decisions that, you could impute that some clinicians believe they haven't really had a myocardial infarction and therefore are not treating with aspirin as a reasonable deduction. Similarly, there's even, if you look at the difference between those between normal and mild, if you have mild coronary artery disease, there's about a 94% chance you'll get aspirin. But if there's nothing there at all, no irregularities, then the rate of aspirin prescription goes down to 82%. Dual antiplatelet therapy reflects the same changes seen with aspirin. So if you turn up with a myocardial infarction, no obstructive coronary disease, there's only a 50% chance that you'll be sent home on dual antiplatelet therapy. If we look at this quality indicator, which is what proportion of people are discharged on a statin, an antiplatelet agent, plus or minus ACE inhibitor or beta blocker, it's fairly good here for those with obstructive coronary disease. It drops down to about 75%. And if you have normal coronary arteries, again, you see this gradation. So clearly clinicians are significantly influenced. So outcome, because it doesn't really matter. This was one of the major reasons for doing this study. So here are the outcomes for a composite of all-cause mortality or a recurrent non-fatal myocardial infarction. And so this is our control group from the population who, as you might expect, have a fairly low rate of events over time. And in red here, with the highest rate, are those who have obstructive coronary artery disease. And interestingly, if you look at these two curves, these are the people with normal coronary arteries or mild obstructive coronary artery disease. They're superimposed. So this was interesting, where, I mean, this is not new in terms of previous understanding. There was thought to be a gradation of risk, but what has not been described before to our knowledge is the rate of events in relation to the normal population. And this is a large series which has demonstrated pretty convincingly that in those without significant disease, there's no difference in outcome, underlining the point that analysis of the coronary angiogram doesn't help you predict how they're going to do. They still have a significant rate of events, which I've outlined here. So in this table, we've presented the group no prior cardiovascular disease, the MINOCA group, and those with obstructive coronary disease, and we've looked at some outcomes. So firstly, all-cause mortality. And you can see, as you would expect, that there's a gradation of risk. Now, we found this very interesting. If you look at cardiovascular death, because they've had a myocardial infarction, so surely that should have some influence. We found that the MINOCA group had very similar and low risk of cardiovascular death, and substantially lower than those with obstructive coronary disease. And if you look at non-cardiovascular death, very similar, but the similarity now is between the MINOCA and the obstructive coronary artery disease. So how might you tease out these observations? And one hypothesis is it's not to do with the coronary arteries. It might be to do with an underlying condition or status that predisposes you to have the myocardial infarction, and that and that's your baseline risk, and that if in addition you have obstructive coronary artery disease, that's associated with additional risk over time. And we did do some preliminary analysis to look at rates of cancer between the two groups, and there's no difference from what we can obtain from available databases. If we look at those who have recurrent non-fatal myocardial infarction, the MINOCA group do have an increased risk of recurrent non-fatal myocardial infarction, but it's less than those with obstructive coronary disease, and for reasons that are not clear, it doesn't seem to translate into increased risk of cardiovascular death. So the conclusion of our study is that if you present with a myocardial infarction and you don't have obstructive coronary artery disease, that you're going to have a risk which is about 50% of those who present with obstructive coronary disease, so it's not insignificant. And your risk remains substantially higher than those in the community who haven't presented. So just turning up with a heart attack itself is going to give you a significant future risk. For reasons that remain unclear, MINOCA patients seem to have a predominant non-cardiovascular cause of death. Interestingly, MINOCA patients with normal coronary arteries and mild obstructive coronary disease have similar adverse event rates, underlining that perhaps the status of the coronary arteries, at least with mild disease under 50%, isn't a discriminator or an influencer of future events. And it looks like persons presenting with this type of acute coronary syndrome get lower rates of ACS evidence-based treatments. Now, what the study cannot answer, and no study can answer, is does it matter? Because we don't know. There's no randomized trials of those treatments in people with non-significant disease. So there are some observational data from a large Swedish registry called the Sweetheart Registry, and it had fascinating results. The weakness is that it's observational, but they were able to do regression analyses controlling for most risk factors, and found that it didn't really matter whether you were on double antiplatelet therapy. That didn't seem to influence future events. Beta blockers were of no particular benefit, and the major things that made a difference in lowering the risk of future events were statins and borderline positive ACE inhibitors. So that's the interesting challenge that lies ahead of us now, to use this data to move forward, to do formal randomized studies and get the information on what is the appropriate treatment for this large group of patients. Thank you.
Thank you, Sean and Mike. That was a fantastic presentation. So do we have any questions from the audience? And like I said before, we're going to just have to use this, just throw it like a netball around and talk into the microphone when you ask a question, just so that the people online can hear. Yeah. Sorry.
Right, is that on? That's good. So you keep saying that you've got evidence-based treatment, but I mean, surely that's flawed. I mean, what pathology are you treating with your antiplatelet agents?
Yeah, so that's a very good question. So the pathophysiological understanding is, once you start looking at these people, the angiogram's no good because you can't see either anything or there's a mild irregularity. So if you do an intravascular ultrasound, though, you will see evidence of an underlying plaque, and you'll often find at the ultrasonography level that there's been plaque erosion. And so because I guess people want to think coherently, they still have believed it would be appropriate to treat with the evidence base for the other, admittedly for the other group, because this group have probably been included in large trials, but because they're a small proportion, we don't have reliable information about them. And I couldn't say to you at the moment that antiplatelet therapy doesn't work, because there's only one study, observational, that suggested in one analysis that it doesn't. And it's still attractive to think that a significant proportion of these people have had an atherothrombotic event. There's no doubt about it. It's just that you can't see much of a residual plaque.
Ivan, just behind.
Sorry, Mike. I was a bit surprised that beta blockers came out with no value in this. So could you explain whether they had bundled all the beta blockers together at different types?
No, it was just the analysis was done just by beta blocker care.
And you don't know why?
Why are you surprised about that?
Well, because, for example, if you look at Takasugi syndrome,
yep,
beta blockers are advocated for that. You're reducing the activity, oxygen consumption, increasing dilation, increasing relaxation of the heart muscle. So, yeah, I am a bit surprised.
But on the other hand, there's a move for those who present with myocardial infarction and fully revascularized. There's no evidence that beta blockers make any difference.
That's true. So it rather depends on the time points.
Exactly, but the evidence for beta blockers early in myocardial infarction is very weak.
In MI, yeah, okay. So in
terms of outcome, we just don't use it.
Yeah,
I would be very surprised if it doesn't work in 90% of people with obstructive coronary disease and reducing hard endpoints. I'd be very surprised if it worked in the smaller group. Couldn't rule it out, and remains open to question. It's an important question, but it looks to me as if the day of the beta blocker is going, and that it would much of it was historical, and it was in groups of persons who weren't revascularized, so they got thrombolysis and they went out into the community with obstructive coronary disease.
Right.
Who knows?
Yeah, I rather think it depends upon the underlying pathology, but yes.
Okay, Tim, just down in the front here.
Okay, so Tim Stokes. Michael, just a quick observation and a question. Great update from me as a GP, and secondly, really good to see the ANZETS QI digitally being used. I think that's a real jewel in New Zealand in terms of having this really good register that you can do research observational studies with. I guess the question I've got is, what was your follow-up in this study? 2-3 years, was it?
Just 2 years so far.
So are you planning on continuing follow-up?
Yeah, we can
really
do that.
See what the 5-year findings are.
Yeah, that would be reasonable.
Hopefully that might help untangle.
The curves out to 2 years look pretty parallel. I think what we're really interested in teasing out is, is there some sort of inflammatory disorder, or do they develop a higher rate of cancer subsequently? That would be that's the real thrust of it, to try and see. There's a bit of a signal about non-cardiovascular death, but we don't know what it is. We know before they come in, they don't have higher rates of cancer, but it'd be lovely to follow them long term and say, is this a marker for trouble later on?
That's a really interesting question.
Yep.
I love the fact that you're talking about the immune system.
Yep.
Immunologist. So in your study, your MINOCA patients, I think if I read this correctly, had a higher BMI, a BMI of about 29.
Yeah.
Did your controls have a high BMI as well? Did you control?
Yeah, we controlled. No, actually, no, we did not control.
Yeah,
but we can, in our regression, we can control.
Right, yeah.
But we didn't. They weren't matched.
Because you often see, you have a higher level of cytokines in people that have a higher BMI, and that may.
Yeah, no, when we did the regression analyses, we controlled for BMI. Okay. Yeah. So the Kaplan-Meier is unadjusted, but when we did analyses, we controlled for BMI. We controlled for everything. Yeah. Which is pretty reasonable in those large numbers. Yeah.
Any further questions just before we wind this up? I think there's another group about to come in. Okay then, so please join with me just once more in thanking Mike and Sean for a fantastic presentation.